I'll just start off with a disclaimer. Lots of our colleagues and our trainees ask how we have the energy to do cancer work and do lots of extracurricular activities like this as well. So that's because, one, we have a perfect work-life balance, me and Wendy. It's amazing. I think Valentine's Day we spent 6 hours just going through our job plans. That's how amazing it is. Circadian has worked wonders for us. Like, all our job sessions are counted properly and we are paid a lot. And lots of free time. And that's why we engage in these activities. So obviously the disclaimers were completely false. So why do we engage in such activities? It's because of this. This is a story, but a true one. December 2019, a 37-year-old referred to Fast Track Clinic with presenting complaints of postcoital bleeding and intermenstrual bleeding, not had a baby, and smear defaulter for the past 16 years. So she has had only one smear, that was when she was 21 years old, and no further smears after that. I do a clinical examination. That's an obvious cervical cancer. Confirmed as stage 2 with all the investigations, and went on to have chemoradiotherapy. And the sad thing is, we know this is preventable, and that's why we are so passionate about cervical screening, and hence we do what we do. So in the UK, there are about 3,000 women affected with cervical cancer every year. But the main thing you have to, the data point that you need to concentrate is 99.8% are completely preventable. And that's what makes us sad when we are in Fast Track Clinic. And at Tayside, we are still seeing about 30 to 40 women with cervical cancer every year. And sadly, most of them are not getting surgery because they are smear defaulters. And we find that in more advanced stages where we can't give them any fertility options, and they go on to have chemoradiotherapy. So how can we prevent? Is it possible at all? Is two things: HPV vaccination when they are children, and as adults to encourage them to go for their cervical screening pathway. We started with vaccinating the girls in 2008. Initially it was a bivalent vaccine, and then we changed to quadrivalent in 2012. When we started in 2008, the group was slightly different. It was a mixed group. The main group was 12 to 13-year-old children, but there was a catch-up cohort up to the age of 18 for 3 years. Then in 2012, we moved to the quadrivalent vaccine. 2017, the vaccine got licensed to be given for men who have sex with men, but this is exclusively available only in the sexual health clinics. And in 2019, boys have been included. A bit late, but boys always catch up, don't they? So truly the vaccine is now gender neutral. When we say quadrivalent, it's not all high-risk viruses it's protecting for. It's 2 low risk, which is 6 and 11, and 16 and 18, which is the high-risk HPV. 2 doses are given, one at the initial dose. If it's at 0, then the second dose should be within 6 months. If we are going to give the vaccine for an older cohort, then 3 doses are needed, 0, 1, and 6 months. And the predicted protection for HPV vaccine is about 70% prevention for cervical cancer. So how effective is the vaccine? It's very impressive data from Scotland, actually, because Scotland is the only place where we have a proper linking of the smears. We have a national database called as CURS, a histological database called as NICAS, and we have the CHI, of course. So we are able to cross-link women across these 3 databases. So about 138,000 women who were born between 1988 and 1996 were included in the study. So the first time, so these were women, 1988 women wouldn't have been vaccinated, but from 1990 they would have been vaccinated. So it had a mixture of vaccinated and unvaccinated women in this group, and they studied what happened if these women come for the first smear test at 20 years of age. This is reference for those who want to do further reading. Tim Palmer is the clinical lead for cervical screening, and Maggie Cruikshank is a fellow colposcopist, but way more cleverer than me or Wendy. maybe more than me, but I don't know about you, Wendy. She's in Aberdeen. So this is what they showed. So the lavender line denotes women who have not had vaccination, and the yellow line is those who have had the 3 doses, because at that time we were giving 3 doses. You can see that this is by year of birth. For CIN1, there isn't much difference between the vaccinated and the unvaccinated group. CIN2, you can see that there is a lot of protection. It's about 86% reduction in CIN2 in vaccinated women. That is a lot. And for CIN3, it was about 89%. So high-grade abnormalities that can lead to cancer, which just with vaccination, it's a massive reduction we are seeing already. So key message 1, ensure and encourage children in your family and friends circle to be vaccinated for HPV. Doesn't necessarily mean your children, but your nephews, your nieces. Have a chat with them and you say, oh, by the way, is the HPV vaccine given? And explore their thoughts if they are not going to take up the vaccine, because the study that is supporting the vaccination program is pretty impressive. Now going on to the second prevention of cervical cancer is obviously screening, because I'm a colposcopist, I need my job security. If you don't go for screening, my colposcopy clinic will not have patients. Okay, no, not because of that. Because there's only 70% protection with HPV vaccine. 30% is still unprotected, so women need to be encouraged to go for their smear test still. So this is the uptake of screening across Scotland. Tayside, we are about 75%, and the national average is about 73%. Out of all the smears we do, roughly about 9 out of 10 smears will be negative. 7% low-grade cytology, and only 1 in 100 will be a high-grade abnormality. So you can reassure women, look here, go for a smear. Most likely it will be okay. There's just a 1 in 100 chance that it will be a problem, but it is a fixable problem much before cancer can develop. So we did an initiative in 2017 from the colposcopy unit. I don't know how many of you have been here for that many years. Have any of you heard of Cervicat in 2017 before? Okay, it was the most amazing program ever. We got a national award actually for best screening initiative. Even if we didn't get the award, we would say it's most amazing because we did it. So we distributed questionnaires to about 214 women and asked them, is there a reason why you would not go for a smear test? This is Tayside women. And 1 in 3 actually said, no, we wouldn't go for a smear if we called for. So we asked, how can we increase awareness? How can we help you to go for a smear test? You can see that the top takers are advertisement and awareness through Facebook, drop-in smear clinics, or evening and early morning clinics to help working women to go for their smear test, because they were finding it difficult during their work time to go for a smear test. So we repeated the campaign in January this year during Joe's Cervical Trust Cancer Prevention Week. I think most of you would have seen us in pink. I hope you saw us because we thought we were very obvious. We created a social cascade because we know that we cannot, provide smear service for all the women in the community. We created a social cascade through awareness programs. So every person who comes in contact with that program will talk to somebody else. Okay, we achieved this through Facebook advertisement, a selfie booth. I don't know how many of you have been to a selfie booth. You missed a lifetime opportunity if you have not been. Okay, and there were lots of information stalls at Nine Wells, Perth, and we went to Tesco for the first time at Riverside this year. We created drop-in smear clinics for the general public and early morning, evening clinics exclusive for Tayside staff who have not been able to go for their smears or who have been overdue. So we kick-started with the information stall on the concourse, and these are our 2 lovely medical students, Dana Hutton and Jenny Wood. They just realized that they're as bonkers as us when they got involved with this project. And the clinics, the pink flyer was for the drop-in smear clinic for the general public, and the attractive animated poster was for women who are overdue for their smears and work within NHS. Those are all our volunteers who did this amazing job, our gynae clinic staff. We did have some support from public health in terms of funding, so thanks to Julie Kavanagh, cervical screening program coordinator. So we managed to screen 61 women who had defaulted with their smears, and absolutely overwhelming what the women said in this clinic. I'll let you read that. But the one that really made an impact for me when I was reading through was, "Thank you for empowering and supporting women in the way that you do. Please keep this invaluable service ongoing." So we might do this again. And then the social cascade was heavily, the medical students supported us. The selfie booth was never unmanned, and they were very happy engaging people to take photographs, distributing the leaflets, and talking to them about cervical screening. This was the stall at Tesco. Couple of our patient volunteers gave press interviews to tell about their cancer journey and to encourage women to go for their smear test. She actually got married within a couple of days of the campaign, so it was really kind of her to come by just before her marriage to give us the interview. And few of my favorite photographs from Cervica. Couple of workmen, that was like a serious, couple activity there. A date at Cervica booth, because NHS works you so hard, you don't get to meet your wife otherwise. Our own Urvuli, we tried to personalize for Cervica, and those are amazing cupcakes done by Wendy for the campaign. There were vagina cupcakes as well. I've taken it out because of obvious reasons. Oh, cervico-vaginal. I'm corrected. Okay. But for the best photograph, we thought we should ask Dana and Jenny to select, because they've been amazing through the whole campaign. So this was their text messages to decide who's the winner. So, drop your gear, get your smear. We love the fact that the postnatal ward whipped out their own props in the form of speculums and got the team involved. Next one. This is a smear campaign. Top marks for one of the best captions of the campaign and for rounding up others to come and get their photos taken. Well done, Dr. McClellan. Yeah. But the winner goes to Dr. Gleaser. How do you pronounce mustache? Just mustache. I mustache if you're up to date with your smear test. We love the fact that Dr. Gleaser's mustache blended in with her lanyard. She had clearly thought about her best angle. All in all, we thought it was fantastic. I can't believe sexual health, takes the glory all the time, But anyway, so we have a small gift for Haika, but Haika has not turned up. Sarah, either you can take it or I can accept it on Haika's behalf. No, you don't need to. There's no name. You can use the vouchers. Yeah, thank you so much. Okay. But my personal favorite, okay, there's no prejudice here at all, okay, and the winner for me was this. He was one of the first men to come and support us for screening, but I don't think he had a choice, okay, so key message 2, ensure women in your family and friends circle have their smear test. But the one topic that I have not touched here is another vulnerable group, which might be very difficult for us to pick up. Women who have been sexually abused in the past or transgender. We need to encourage them actively to go for their smear tests. Yeah, I'll hand over to Wendy now.
Thank you. Oh, where's it gone? We break while we find my slides. Thank you. Good. So I'm going to talk about HPV testing in the context of screening, and Kalpan has already covered vaccination. So the good news, as you've already heard, is that vaccine is very effective. We have very high uptake rates in Scotland. Over 90% of eligible women have taken up the opportunity for vaccination in Scotland. Sadly, it's not the same across the rest of the world. And we know that that confers at least a 70% protection against the development of precancer and cancer, probably greater than 70% because of the effect of cross-protection against different HPV genotypes and now herd immunity as well. So we're even talking about possibly eliminating cervical cancer, certainly in Scotland and maybe in the Western world. But the bad news is that globally that's going to be much harder. HPV infection and cervical cancer is unfortunately very common in low-income countries. There's no systematic vaccination yet in these countries. There's a high background incidence of HIV, and sadly there's very little screening in low-income countries. I might talk about that at a future grand round. But even in the UK, as Kalpan has said, we don't have 100% protection against HPV, even in unvaccinated women. But the other thing is we have a large cohort of women who have not been vaccinated. So as the previous slide showed, if you've been born since the mid-1990s, the chances are that you've been optimally vaccinated against HPV before you've become sexually active. People born in the early 90s may have been vaccinated in the catch-up campaign, so their protection will have been less because a proportion of their cohort will have been sexually active by the time they were offered the vaccine. But people born before the 1990s won't have had the option to be vaccinated at all. So we're still dealing with a huge cohort of unvaccinated women. So we still need a screening test in the UK, but the screening test needs to change. So a little bit about HPV. This is von Kousen, who is the Nobel Laureate Prize winner for elucidating the link between HPV and cervical cancer. If you want to read listen to his acceptance speech on the Nobel Prize website, it's very interesting actually. And him and his team showed that infection with high-risk human papillomavirus is a necessary precedent for development of cervical cancer. The viral DNA gets integrated into the host genome. It facilitates production of oncogenes, particularly the E6, E7 oncogenes, and that leads to immortalization of the host cells and eventually malignant transformation. But HPV is not just about urogenital disease. There's lots of different types of HPVs, at least 100 different types. So there's at least 60 types of cutaneous non-mucosal HPV that cause things that we've all heard of, like skin warts and verrucas and lots of other things that I don't know about because I'm not a dermatologist, but I'm sure Charlotte knows all about them. But in terms of gynae, we're talking about urogenital HPV. But urogenital HPV is divided into two different groups. So we have the low-risk types, which is predominantly type 6 and 11, and that causes genital warts and a lot of low-grade cervical abnormalities, but it doesn't cause cancer, those types. And then we have the high-risk types of HPV, which are predominantly type 16 and 18, but there's at least 14 types of high-risk HPV altogether. And those are the ones that can cause high-grade cervical abnormalities, precursors of cancer, and eventually cancer. It's not just cervical cancer. High-risk HPV can cause cancer in about 50% of vulval cancers, quite a lot of anal cancers, quite a lot of oropharyngeal cancers, and some penile cancers. But the difference about cervical cancer is that it's almost exclusively caused by HPV. So it's almost impossible to develop cervical cancer if you've not been exposed to the oncogenic HPV virus. And that's a list of all the types, and you can see that 16 and 18 that we currently vaccinate again causes about 73% of cervical cancer, but the other 30% are caused by the other 12 high-risk types. Bit of background to HPV. HPV's been around for a long time, probably as long as human history. It's a very ancient virus, and papillomavirus isn't just in humans, we see it in animals as well. I always say to the patients it's skin deep, it's a mucosal disease. It infects the skin and the mucous membranes, but it doesn't get into the body. It's not a systemic disease, and I think it's because of that it's difficult for the immune system to recognise it, and it takes a long time for the immune system to clear it because it is literally just in your skin. It's ubiquitous, okay? It's very, very common. If we track women or men who have ever been sexually active, their chance of carrying HPV at some time during their life is 80%. 4 out of 5 of us who have ever been sexually active will have been exposed to HPV. And it's usually asymptomatic, and it's usually transient. So most people are exposed to it, they carry it for a couple of years, and then they clear it. But persistent infection in those people who can't clear the virus is potentially oncogenic. It doesn't happen quickly, it takes decades. We're talking about 10 or 20 years from first exposure to HPV to the development of cancer, so we've got plenty of time to intervene. So our current screening programme, this is soon going to be history, but I think to put it into context I need to speak about this, is that women go for a smear test and they have cytology. So we look at the cells under the microscope, and there's really 3 outcomes. Either the cells are normal, in which case women are recalled in either 3 or 5 years, depending on their age. Or the cytology is high grade, so we see moderate or severe dyskaryosis, in which case the women come to colposcopy. So that's not contentious. But we have a group of women who have low-grade cytology, so that's what we call borderline or mild dyskaryosis. And these women in Scotland at the moment get repeat smears every 6 months, and they get colposcopy either if they progress to a high-grade smear or if their low-grade smears are persistent. Okay? But that leads to a group of quite worried women. It means that we do send some women to colposcopy with persistently low-grade smears who are actually not carrying the high-risk HPV. So there's a risk that we might inappropriately overtreat some women. And there's a risk that some women who have high-grade disease won't get picked up as quickly as they maybe could. Just an aside for the students, because the students sometimes get a bit muddled about this. In England at the moment, England sort out this group of patients by doing HPV triage of low-grade smears. Okay, so a low-grade smear will then be sent for HPV testing. Women who carry the high-risk HPV virus will be sent straight to colposcopy, and women who don't will be kept on routine recall. But this is about to all be history, because in the whole of the UK it's now about to change. Okay, and this is what's going to happen in a few weeks' time. So if we go for our smears, it will be the same sample, same speculum, same cytobrush, sample put in the same bottle. So for the smear takers, it's exactly the same, but it goes to a different lab. So the first test that we do is a test for the high-risk HPV, not just 16-18, but for all the high-risk HPVs. If a woman is negative for high-risk HPV, that has a very, very strong negative predictive value. So we can say to those women, you don't need another smear for 5 years. And there's very good evidence for that. However, some women will test HPV positive, and then the same specimen, they don't have to come back for another test, will be sent for what we call reflex cytology. If that cytology is positive, any grade of dyskaryosis, those women will be referred to colposcopy. If that cytology is negative, we will reassure women that they are carrying the HPV virus, but the HPV virus hasn't caused any harm. And those women will be continued to be screened on an annual basis. Okay? If the HPV clears, they will go back to 5-yearly screening. If they develop any dyskaryosis associated with the HPV, they will be referred to colposcopy. At the moment, the plan is, because we will have a group of women who will be persistently HPV positive with negative cytology, we don't quite know how that group's going to pan out, but those women at the moment will be referred to colposcopy after 3 consecutive HPV positive smears over a 2-year period. We think the chance of disease in these women will be quite low, but we're not doing this yet, so we don't know for definite. And that's going to be the same across the whole of the UK. The only thing that I think the English are doing differently is that their HPV negative women are still going to be recalled every 3 years if they're under the age of 50, which is the sort of same screening interval that we have at the moment. So, for example, if 100 women go for cervical screening in the new system, 87 will have an HPV negative result, they won't need cytology, and they will be on 5-yearly screening. 13, however, will have an HPV positive result. 4 of those will have dyskaryosis and will come to colposcopy. 9 of them will be kept on annual screening on the basis that they're carrying the HPV virus, but they don't have any changes in the cells. So what are the implications of this? We're doing this because it's a better test. We're doing this because we know the existing test is very, very good, but it could be better. We know that this will pick up and prevent more cases of cervical cancer. But there's already an issue with women not coming to their smears. Women don't come for their smears because they're busy, they're worried, they're embarrassed, they think it might hurt, they're confused. We don't want to add to that they don't want to come to them for their smears because of stigma and taboo and worry about HPV infection. Health Scotland are about to launch a huge amount of information on their website, so anybody who's involved in any way with talking to people about their results or taking smears must go onto either the NHS Scotland website or Health Scotland website, because all the information will be there. We've already mentioned Joe's Trust. Joe's Trust is a fantastic charity that supports women with the diagnosis of cervical cancer, but it also supports women who are worried about smear tests and the implications of that. And they've got a huge question section on the implications of HPV testing. And I would encourage everybody, particularly medical students, to go onto this website. And this is one quote: "When I realised how common HPV was, my guilt did subside. There wasn't much else I could have done to protect myself. The vaccine wasn't available when I was at school. It was just that my body didn't clear the HPV." I've been too long. So, key messages about HPV infection: it's often asymptomatic. It usually resolves spontaneously. So a lot of us carry it, but most people get rid of it within 2 years. But it's persistent infection that causes the cell changes that eventually lead to cancer. So the sequelae of infection are due to failure of clearance. They're not about acquiring an infection. It's spread by direct physical contact, skin-to-skin contact, any genital contact, not just penetrative intercourse. Skin-to-skin contact, and anyone who is sexually active is at risk. And condoms and dams give some protection, but they don't give complete protection. Why do some people not clear it? We actually don't know. We know a couple of things. We know that women who are immunosuppressed are less likely to clear the infection, and we know that smoking plays a part. So it's a good opportunity to have a discussion about the importance of smoking with women. And now we're going to go on to, I don't know how much time we've got, but we've got
30 more minutes, so we'll just...
That's good.
We thought we'll switch off the video for this, the video recording, because we want you to discuss with us